Oh, welcome back. So we'll start our next session. The first talk will be done by Professor Graham, and he'll talk about the effects on trainee doctors and medical students by EM teaching during COVID-19. Professor Graham, please.
Thank you very much, Ralph. Can you hear me okay?
Yes.
Okay, excellent. Let me just share my screen if I may. Okay, can you all see that all right? How's that? Okay. Thank you. So this session is really thinking about how training and teaching have been affected by COVID-19. And Professor Grace Lloyd just mentioned about the impact on teaching, and I know that the others will come after me to discuss this in more general terms, but what I wanted to spend a few minutes on was to discuss the impact of COVID-19 on emergency medicine teaching, particularly for our trainee doctors and our medical students in Hong Kong. And I'm the first to say that there are more than medical students in our emergency departments. We have student nurses. We sometimes have students in physiotherapy and other professions allied to medicine as well. And we have had many ambulance personnel on training as well in our departments over the years as well. I'm also very conscious that some of our audience today are indeed medical students, and I'd encourage you, if you have comments on this or indeed on any of the talks in this session, don't hesitate to add your questions to the discussion at the end of the session. So I thought I'd go through a few things here over the next 15 minutes or so. How do we teach in normal times? In peacetime, as many people have said over the last few days, what the effects of COVID-19 are on student and trainees teaching and training, and then think about where we go in the future. So I showed this guy's picture back on the first day of our symposium on Saturday. This individual's called Maurice Ellis. He is regarded universally in the United Kingdom as the father of emergency medicine. In fact, at work, he was often called father for reasons unknown to me, but it sounds like he was just one of those senior doctors that had a kind of overall presence in his department. He was a surgeon by training, and he was the first consultant in charge of the Casualty department, as emergency departments were known, back in the late 1950s, and that was in Leeds General Infirmary. And a few years after he was appointed in 1952, he wrote the first edition of what was called the Casualty Officer's Handbook. And this really was the first effort anywhere in the world, really, to have a formalized set of guidelines on managing the conditions that present to an emergency department. Interestingly, in the first edition of that book, and I've not reproduced it here just for reasons of time, but things like resuscitation were not included because they didn't exist in those days. Defibrillation was never mentioned because it didn't exist. It did come in subsequent editions, but not in the first one. But the emphasis was really on the management of minor trauma, wound care, and minor traumatic injuries. Fast forward a little bit, and many of you will be familiar with this book, the Oxford Handbook of Emergency Medicine. Many of you will have seen and will possess an Oxford Handbook of Clinical Medicine. I used to call it the cheese and onion book because it was yellow and green. And this is its successor, which was the Oxford Handbook of Emergency Medicine in the UK. Jonathan Wyatt was the lead on this when I was a registrar in Edinburgh back in the mid-1990s. Jonathan was the senior registrar, just about to become a consultant, and he went on to run all of the 5 editions of the book so far. Robin Illingworth, funnily enough, was also a consultant in Leeds General Infirmary and St James's University Hospital in Leeds. Robin had the most encyclopedic knowledge of any human being I have ever met, and that's saying something. There was really nothing that he didn't know. And I was lucky enough for the 3rd and 4th editions to be asked to help to update it and put this together. The book, thankfully, this isn't an advertisement because the book is now into its 5th edition. Kirsten Hogg, a trainee around the same time as me, has become Kirsten DeWitt over time, and Jonathan still leads the book. But it's sold an awful lot of copies. It's over 200,000 copies now, and most people seem to find it a very useful collection of guidance, especially when you're on your own in the middle of the night trying to deal with a patient with something for the first time. But Hong Kong has not lost out on this. I'm afraid that, I'm sorry, I couldn't find a particularly good picture of this, but this is the Practice of Emergency Medicine textbook, which has been produced by the Hong Kong College of Emergency Medicine, our professional body in Hong Kong. And it's now into its 2nd edition. It's a very good guide to how emergency medicine in the modern era in Hong Kong can be done. But the Hong Kong Society for Emergency Medicine and Surgery started this off back in the 1990s with 4 core training manuals, which again were the first written instructions specific to Hong Kong for people starting off in the discipline. Now, I use this picture all the time. It dates from a few years ago now, but it's a good reflection of how busy our departments can be. I would love to tell you it's got less busy since COVID started, but it's gone up and down a bit. But we have some problems with emergency medicine teaching in general, particularly for the trainee doctors. We all work on shifts. Getting us together to do training is in itself difficult, and most medical training revolves around having a meeting, having a lecture or a discussion or a tutorial. When someone always has to be on duty, it becomes very difficult to get people together to do that training. Someone's always on holiday, someone's always on night shift, someone's always sick, and someone's always just taking a day off after their night shift and or doing something ridiculous like getting married. I remember having a very vigorous discussion with one of my consultants when I told him I was taking a couple of weeks off to get married. He thought that was just ridiculous. But in the end, I did manage to get married, and that's another story. But yeah, it's hard to get people together to actually train them. Another challenge we face is that everyone comes to the emergency department with a different level of experience. So we may have someone who has very experienced, say, in orthopedics or in general medicine or in pediatrics, but has absolutely no idea what to do with the other patients who present. And in fact, the thing that you would do to a patient, say, in the medical clinic is often very different to what you would do to a patient with the same condition in the emergency setting. And the other problem that comes is that the clinical situation, which might only happen to you once in your entire life, could happen to you tomorrow, and that could be before you've had any training in it. One of the most challenging and difficult and unpleasant scenarios that we ever have to deal with in the emergency department is a peri-mortem cesarean section for a maternal cardiac arrest. And I was fortunate enough to get through my entire training and into many, many years as a specialist before that happened in Prince of Wales a few years ago. It happened on the first day of the Chinese New Year. Very unpleasant morning it was too. And we all thought, those of us who were involved, that the chances of this happening again in the next 10 years was next to nothing. We did another cesarean section less than a month later, and we've never had to do one since. So the irregularity of critical situations can be a real challenge, and it has no consensus with the training that you may or may not have received at that time. It would be easy to say that compulsory training should be enforced to make it happen, but in practice it's extremely difficult, a bit like the vaccination discussion we just had with Grace Loy and Ben Cowling. It's a great idea in theory, but it leads to huge numbers of challenges and problems. And in reality, what we've needed for a very long time is the ability to have asynchronous training. So training not together, but giving the same level of training to each individual. But in practice, this has been very hard to do. How about medical students? Well, medical students come for very short periods of time. In total, out of 6 years of medical training, and certainly in CUHK, you'll get 8 days of emergency medicine exposure. I don't think it's unfair to say, especially for those of you who are just at the end of your final year, the enthusiasm for clinical medicine at the beginning of final year is very high, but towards the end, people are obviously and very reasonably concentrating more on passing their finals than on turning up to see patients. We know that examinations drive learning for medical students, and that is a simple fact of life. If there's no exam, people really don't put a lot of time into it. But what that means is that most curricula, and Chinese university is no different from anywhere else, are massively overloaded with tests. And medical students get tested all the time, and we've been reluctant to add yet another test to medical students' exposure and experience just to drive learning, because we feel it's important that people see patients rather than just learn facts. We have a particular problem in emergency medicine in that we don't have many academic staff. Our clinical colleagues in the hospital authority are incredibly supportive, and they are themselves very keen and very effective clinical teachers, for which we're very grateful. But the reality is they have a busy job to do too, and it's hard to actually provide that teaching. It means, therefore, with 8 days out of 6 years, that the opportunities for clinical exposure are relatively limited, and especially with the reality of how busy the ED shop floor can be. And it means that it's resource intensive, but also difficult to do. So what was the effect of COVID-19 on teaching? I mean, in essence, it was bad. It was a detrimental effect. It was immediate. Professor Wong, our next speaker, will talk more of this in a general sense, but essentially students were excluded from the hospital completely at the beginning. And there was a bit of a lack of recognition from senior staff in the Faculty of Medicine that the emergency department was a high-risk environment. People like Grace Loy and David Hui absolutely got it right away, and they were, very concerned. But some of our other staff who are possibly not so familiar with the emergency department of the modern world couldn't work out why this might be a risky place for students. Grace mentioned that we had difficulties with PPE supplies at the beginning of the outbreak, which meant we were limiting what personnel could go into the department at any time at the start. And I think it would be fair to say that the hospital authority has an absolute aversion to risk when it comes to student welfare, and that obviously has good points and bad points. The hospital authority does not want to see students come to harm, and that's a good thing. But they also want every medical student to be trained really well by the time they become a house officer. And it's clearly impossible to have those two components acting together. You wouldn't allow a pilot to fly you from Hong Kong to Singapore unless you knew they had actually been in a plane before, had a few takeoffs, a few landings, and you knew that he or she was capable of that. And yet, there are people within the hospital authority, and indeed some within the university, who think you can do that with doctors. I'm afraid you can't. And that's one of our real challenges. So what did we do next? We converted some of the all of the online material. We wanted to get everything as much as we could online, and we used Zoom for that, which I think had some success, but I think we could see it was variable at the beginning. And then we subsequently went back to the clinical environment with exposure to the wards. We still haven't let anyone set foot on the emergency department shop floor, and the exposure in the wards has got to be under direct clinical supervision. There's no problem with that except for the amount of time it takes for clinical teaching staff. It becomes very difficult and time consuming to do that. And it means that students get exposed to patients who are relatively cold. Well, certainly, let's say warm. They're certainly not as hot as the emergency department patients when they come through the door. The clinical record, the clinical exposure recording for contact tracing is paper-based at the moment. There is an app available, but it doesn't work particularly well and is really not a great situation at the moment. Now, how about the doctors? Well, I think in simple terms, the doctors also had a fairly big hit to begin with, in that we had to switch to enhanced infection control training and infection protection for all the medical staff, the nursing staff, our healthcare assistants, our cleaning staff, everyone, our radiographers, everyone had to be protected first, and that rightly was the priority. Everything else was of secondary importance. But there was a very steep learning curve in those first few months. We had new data coming in every day that was changing what we do. I think staff were very stressed. Many of our colleagues simply wouldn't go home because they wanted to protect their families and reduce the risk. They were tired, they were stressed, and it's not a good environment for learning and teaching in those circumstances. But I do think things got better. We had less ED patients, kind of regular category 4 or 5 patients turning up because people were frightened to come to hospital. But the ones who did come, who were possibly infected with COVID, did need to be carefully managed. And we had a few months before the tents went upstairs and went into the car park, and there was a lot of patient interactions with high-risk patients using all the PPE we had. And the testing protocols seemed to change every few days initially. Paul Chan's told us about the challenges of testing and the different ways you can do things, and I think it took us a long time to get that right. But we did implement regular Zoom teaching meetings every Friday morning, and those meetings are for all of the department doctors. Some of our students have joined them recently, and in fact, I think has led to a higher attendance than we would have had if we were meeting face-to-face. We've covered a variety of topics and cases, and as we've got more familiar with the format, it's led to more participation from a bigger variety of trainees and teachers, and I think it's been extremely positive. The monthly trainee training meetings have not been quite so great. We've continued it as and when we can, but the workload and the different phases of the pandemic have made that less easy. But now our patient numbers are returning to normal as the fourth wave begins to fade, and that is changing the way we do this as well. So the winners, I think, ultimately have actually been the doctors. Zoom has given us a solution to that asynchronous learning problem. And that really has been a fundamental problem in all the years that I've been doing this specialty. And I think we should continue to use Zoom to encourage that participation over time. I do think the medical students have lost out. There's a lack of exposure on the shop floor, and I think that could lead to some problems. I think the question we have to ask, and again, I'm keen to get views on this and questions on this, is this really important? Some people feel it is. Some people feel it's not. I suspect the factual knowledge acquisition is not really affected that much. You can study books, and medical students in Hong Kong are very good at studying books, but the experiential learning is profoundly affected, and I think you learn an awful lot by seeing patients. The question is, do you need to do it in year 6, or can it wait until later? But the emergency department environment itself is really very difficult to simulate properly. And I think that gives us some important questions that I think are currently unanswered. Will this affect a student's perception of emergency medicine as a specialty? If you've never seen the specialty, what do you think it will be like as a career? Will it affect our recruitment to this specialty in the future? We don't know. And in those who work in the department, that might not be the end of the world, but those who don't regularly work in an emergency department, those who come to respond to trauma calls, for example, or obstetricians responding to an emergency in the department, how will that affect their understanding and awareness and behaviour in our unique environment? Very briefly, other countries did different things. The UK brought forward final year graduation to allow those students and young doctors to join the healthcare workforce early to help patient care. In Australia and New Zealand, clinical students were rostered on shifts and given PPE, and they got on with it, and there's no reports of infections. And in the US, most schools continued with clinical teaching. So we could abandon shop floor teaching and just say it's too risky. We could limit clinical exposure, we could give you PPE, and we could say don't go into the high-risk areas like our negative pressure rooms. Or we could directly supervise you in the ward as we've done before and accept the limitations that that brings. We could simulate an emergency department, but that would need space, it would need money, and it would need simulated patients. And those restrictions, I think, are very difficult to deal with in our setting in Hong Kong. And other countries have started going into things like virtual reality and used VR training, again, dedicated staff and software. We're looking at the moment with colleagues about things like game-based teaching and online EM case-based training options. Again, we'll need to see if they actually work, or at least if they're as good. And blended learning approaches definitely have something to offer here. So in summary, I think COVID-19 has been a curse for our students, in emergency medicine at least. But I do think it's given us a push and a solution to some of the recurrent problems we've had with training our ED doctors in the department. And I think we need to continue to consider what are our best approaches to this. And we need advice from those experts who are teaching more generically than us to see what we can do to improve and maintain our teaching. But I think we also need to do some more research on this and identify and invest in those new approaches to try and sort this out. Because the reality, as many speakers have already said, is that these infectious diseases, COVID, and the ones we haven't got yet, are not going to go away. And we need to live in the reality of that new world and be able to teach and train our students and our colleagues. And I will stop there and hand back to Ralph. Thank you.
Thank you very much, Colin. The shift from seeing real patients to some form of online learning or Zoom learning turn into winners and losers among trainee doctors and medical students, a real dissection of our current problem in A&E in Hong Kong and training.